What's up, guys? Welcome back to From the Ground Up. And today we are going there. We are talking about the great debate of Kegel exercises, which if you've followed me for any amount of time, you know that I have a strong opinion on these. And if you're new to me or to my content or to the podcast, welcome and buckle up because this is a strong debate in our field and in, the gynecology field in general. And we're going to go there today. Most people think that being anti-Kegels, as I claim that I am, means that I am simply pro pelvic floor relaxation. But for me, I believe it actually comes down to being pro determine the why, find the root cause and fix it for our patients. Being anti-Kegel simply means I am anti-Band-Aid. I'm anti-compensations. I'm anti-cover up the symptoms without actually fixing them. And it means I'm pro finding the why, finding the root cause, why the pelvic floor isn't doing its job in the first place, and fixing that piece of the puzzle. So I'm going to share kind of 3 points with you guys that is going to drive this home and hopefully convert you over to the anti-Kegel side with me. Come on over here. The water's great. One of the big reasons that I am just so anti-Kegel, I just think that they are so ridiculous and dumb and pointless. To be frank, we're just starting off with a bang here, aren't we? The pelvic floor doesn't work that way. Frankly, Kegels don't make sense because the pelvic floor, that's not how any of this works, right? I'm picturing that meme that's like, that's not how any of this works. The pelvic floor is made to work automatically, you guys. It's made to respond to pressure perturbations. It's made to respond to load. It's made to respond to biomechanical changes throughout the chain. It's made to respond to anything that life throws our way, whether it's our patient sneezing or us going to deadlift 300 pounds. The pelvic floor is made to automatically respond to those activities, okay? And not only respond, but it's also made to anticipate these things. It's made to anticipate perturbations in loads and sneezes and all of those things. This idea of the pelvic floor being this automatic group of muscles is a huge reason that teaching Kegel exercises, utilizing Kegel exercises, essentially cueing our patients to squeeze and lift the pelvic floor muscles voluntarily at any time doesn't make sense because you're not retraining the way that the pelvic floor muscles are made to work. They're made to be automatic and not to be this voluntary squeeze and lift that we are forcing our patients essentially to do for the rest of their life to manage their symptoms, okay? It's a way to manage things like pressure and, you sneeze and you leak a little bit and we might teach our patient, well, just squeeze your pelvic floor when you sneeze and you won't leak anymore. Frankly, I call that a Band-Aid. I call that all you're doing is closing off the outlet essentially and keeping the pee in that way, but you haven't actually fixed the reason that the pelvic floor was failing in the first place. You haven't found the why and you haven't fixed the root cause, okay? Think about like our multifidi muscle or our transverse abdominis muscle, okay? Both of which are highly integrated with, related to pelvic floor function, and both of which we learned PT School 101 are automatic muscle groups. The multifidi and the transverse abdominis is made to anticipate movement. It's made to respond to movement, okay? It's made to, if we go to pick up something out of the trunk of our car and pull it up, our multifidi and our transverse abdominis, number one, need to anticipate that we're about to pick up a box out of the trunk of our car because our brain knows we're about to do it, right? And so that nervous system connection primes those core muscle groups to fire to support our spine and to manage some of those interabdominal pressures that are going to happen when we pick something up. And also, they're made to respond to what happens during that load during that movement, right? So we pick up the box out of the trunk of our car and we're turning to put it in the shopping cart. I don't know. I'm returning a purchase. I return things a lot. They're made to do that. And we learn that, right? We learn about the functions of those muscle groups. And, when we're rehabbing things like low back pain, hopefully we're not out here being like, oh, just squeeze your abs, just go do some ab squeezes and go do some back extensions. I don't know. Like we would never, right? We would literally never. So why do we think the pelvic floor muscle group, which, by the way, is besties with the multifidi and the transverse abdominis, okay? Why do we think that's going to be any different? Well, it's because this is what people have taught us for years, so it's not your fault. But here I am. I'm here to tell you it's dumb, okay? It's dumb. I just want to encourage you to think of it in that picture because even if we know, like, the pelvic floor is part of the core, like it works with the abdominals, it works with the diaphragm, it works with the multifidi, like all of that is true. And if that's true, why are we training the group of pelvic floor muscles differently than we would train the transverse abdominis and, multifidi? I always think about back in PT school. I don't know if you guys heard this in PT school, but I'm going to go on a side tangent for a second because it's funny. But I always remember this story hearing about the multifidi muscles and how, when we lose strength overall and people were getting imaging done on their spinal musculature and they looked at the multifidi. And I remember my professor being like, it's fatty infiltrate. The multifidi fill with fat, which I think is like so funny and weird. But to strengthen them, we don't just say, oh, you have fatty multifidi muscles. We actually strengthen the core as a system, right? No one's out here being like, go do back extensions to strengthen your multifidi. That would just be dumb. In the same way that giving pelvic floor contractions or volitional pelvic floor control during functional movement tasks is dumb. It is dumb because that's not how any of this works. So I want to encourage you to be thinking of your patients who maybe you do cue a pelvic floor squeeze whenever they sneeze or cough in order to keep them from peeing their pants or keep them from feeling like their bladder's going to fall out. It's all for their good. I know you're trying to help them. And I just want to encourage you to be open-minded to hear what I have to say about this concept, because in truth, what we're doing when we say, just do a Kegel when you sneeze or do a Kegel when you deadlift the weight or whatever, anytime we cue that volitional contraction, aka a Kegel of the pelvic floor during these functional movement patterns or functional things that are happening in our everyday life, we have simply given them a Band-Aid. We have given them a compensatory strategy, okay? Which I know a compensatory strategy can be useful sometimes in general, right? But in what other part of physical therapy or occupational therapy do we give someone a compensatory strategy and call it fixed? We literally never do, okay? And so if you're doing these things, just recognize that by cueing pelvic floor engagement during these functional tasks, during the hard part of a movement, during a cough, a sneeze, a laugh, a jump, of whatever it is, tip of the iceberg, right? You've barely figured out what is going to help your patient. You've only put a Band-Aid on their pelvic floor. You haven't fixed the root issue, okay? So that's the first major point of why I think Kegels are so dumb, is because the pelvic floor doesn't work that way, yet we're being taught to cue Kegels, pelvic floor contractions, and calling it good, calling it fixed, okay? And yeah, I know people are like, yes, but the pelvic floor has volitional capabilities. We are able to turn it on voluntarily. So, I know there's going to be people out there listening that's, saying, yeah, Becky, you say it's supposed to be automatic and responsive and anticipatory, but why would we be able to have volitional control over it if we weren't supposed to use it that way? And I would come back to my same examples of, are you going to give someone quad sets for the rest of time for their knee pain and call it good? No, you're not. You're going to actually, hopefully, we are integrating functional movement patterns and, whole body strengthening and looking above the knee joint and below the knee joint and treating range of motion limitations and treating strength limitations that we see up at the hip and the pelvis, right? Like all of these things, we have come a long way for knee rehab. Okay. All of these same concepts we can apply to the pelvis and to the pelvic floor. That's not how it works. It does not need to be trained volitionally to be able to restore its automatic capabilities. We do need to figure out how to do that, and I'm going to teach you how to do that. Let's go on to the next big reason of why I hate Kegels, and I think they're dumb, and I'm anti-Kegel. If anti-Kegel meant simply, okay, I'm anti-Kegel, that must mean I'm pro pelvic floor relaxation and lengthening and all of that stuff. That still does not get to the root of why the muscles are tense in the first place. Let me explain. A big argument, if you will, that I hear in this like Kegel debate is, well, yeah, not everyone needs to be doing Kegels because most people have tension and most people actually need pelvic floor length and pelvic floor relaxation and like tension release and all of these things. And I'm like, yes. And a lot of these people are saying, well, I don't give Kegels, but I just do, pelvic floor relaxation exercises. And I'm like, love that for you. And tell me how that gets to the root cause of the pelvic floor not functioning. What comes to mind for me for pelvic floor relaxation, right? Things like traditional happy baby pose, child's pose, breathing, right? Breathing exercises in these positions in an effort to use, the pressure changes as we breathe and use our diaphragm muscle, right? In an effort to use those pressure changes and the effect that we know that has on the pelvic floor, right? We know that when we breathe and we inhale, the pelvic floor naturally is going to kind of expand and descend and lengthen and all of those things. So people have taken that knowledge and they now say, okay, well, let's just put them in a child's pose and give them breathing exercises and call it good. Because I'm not giving them Kegels because Becky says not to do Kegels and I want to listen to everything Becky says. No, I'm just kidding. I'm going to go to the opposite end of the spectrum and I'm just going to give them pelvic floor relaxation exercises, or I'm just going to do internal manual therapy releases because the pelvic floor is so tight and there's trigger points and there's so much tension and we just have to release it and all of the things. And I want to challenge you here because so many people think that being anti-Kegel, quote unquote, means that I'm not giving Kegel exercises, but I am solely saying your pelvic floor is so tight, we just have to relax it. And that's not what I'm saying. What I'm saying is this is not how the pelvic floor works. We don't just muscle it into strength, quote unquote, with all of these Kegels and squeezes. And on the other side of the coin, we also don't just lengthen it and relax it, quote unquote, with all of these relaxation exercises. And the point is, the reason being of why that's not the camp I'm in, of why that's not what I mean when I say I'm anti-Kegel, is because that still has not uncovered the root cause of the tension, right? Like, let's say your patient does have pelvic floor muscle tension. Let's say they do come to you with chronic pelvic pain and you do an assessment and you're like, oof, girl, like you got some tension there. You got some trigger points, like I'm feeling it. Like, of course, I'm not going to give this person Kegel exercises, right? Like I would never gasp, right? Becky says not to do that. I just want to challenge you again here that if you go the full opposite end of the spectrum and all you're thinking through is relax their pelvic floor, breathing exercises, stretches, all of those things, you still truthfully are giving them compensations. You're giving them Band-Aids. You're giving them ways to manage their symptoms. You're giving them ways to feel better in the moment, right? All of the breathing exercises, the stretches, the manual release, all of that stuff feels better because you've temporarily, that's the key word, you've temporarily reduced the pelvic floor muscle tension that is driving some of these symptoms. But you didn't fix why the tension was there in the first place, right? So it kind of keeps coming back to this, like, that's not how any of this works. And it's not either or. It's not you have a weak pelvic floor, so you need to strengthen it with Kegels. And it's not, well, actually, most people have a tight pelvic floor and they need to relax it. Like, that's not the debate I'm in. I know you hear that a lot. I know that you hear those are the two sides. But I'm here to tell you that I'm not on either of those camps, okay? So if we're thinking big picture pelvic floor, and if we're like, well, okay, well, if it's not about just relaxation, if that's not the opposite end of the spectrum of being anti-Kegel, what is? Okay, we're going to get to that. I want you to stay with me here because I want you to just be putting on, your thinking hat, if you will, That's so cheesy. But put on your thinking hat with me and be open to kind of this mindset shift of the pendulum swinging side to side is not what you've thought it is. And it's not what people are saying it is. It's not what people are out there debating on Instagram, where you have to be, pro Kegels / strengthen pelvic floor, pro relaxation, everything's tight, relax the pelvic floor. It's not any of that stuff. So point number 3, we're going to move on here. Point number 3 of why I am anti-Kegel, Kegels are dumb, they don't make any sense, yada, 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 is that the pelvic floor is influenced and impacted by literally everything else, okay? Literally everything else in the body, everything else in our environment, everything else in our nervous system, in our gut, and everything influences and impacts the pelvic floor and its ability to function, okay? And as a pelvic floor therapist, this is our literal job, is to figure out what is the thing or things, it could be multiple, it usually is, what is the thing or the things that are causing the pelvic floor muscles to be dysfunctional, okay? That is our literal job. Pelvic floor therapist, boom. Our job is not to determine, is this pelvic floor tight? Is this pelvic floor weak? Our job is to hear our patients and what they're telling us and hear their stories and be a detective and figure out why. I mean, it literally sounds simple. Like me just explaining this to you, I'm literally like, this sounds so simple, but it's not, because if it was, everyone would be doing this. And I would not be out here on this hill being like, stop thinking about only the pelvic floor, right? So let me explain a little bit more of this third point, being that the pelvic floor is influenced and impacted by literally everything. Okay. And it's our job to figure out what it is. So I have a saying that I use often with my patients, with people who take my course, with my clinical mastermind students, with my team whenever I'm training them and, helping them with patient cases. And the saying is that the pelvic floor is a victim. Okay. And what I mean by that, by the pelvic floor muscles being a victim, is that this is simply where we are seeing the symptom breakdown. Okay, so this is where we're seeing things in our patients like leaking, pelvic organ prolapse, painful intimacy, constipation, pelvic girdle pain, like all these things, right? Like I list off all these symptoms that we treat in our patients. So this is where we're seeing the symptom, where our patients are feeling the breakdown and the dysfunction, but it is unlikely that the pelvic floor is the cause of the symptoms and of the breakdown. Okay, so just because the pelvic floor muscles are not keeping pee in, or just because this patient is having pelvic girdle pain and whenever they stand up out of the chair and turn to walk out of the room, they get lightning crotch, right? We've all had those patients that tell us that. Just because we're seeing stuff at the pelvis and at the pelvic floor does not mean that the pelvic floor is the reason it's failing, to be frank. Okay. And there's so many possible causes for this. And this is actually why I created my no Kegels, quote unquote, course, because I want you guys to be aware of all of the possible causes. And in this course, I actually walk you through how I do my assessment, how I do my evaluation, what questions I'm asking, what functional test I'm looking at, what manual things I'm doing to assess, the rib cage, the pelvic floor, all the things, what functional movement tests that you can be observing and watching. Like literally, this is my course. My course is zoom out of the pelvis and find the root cause of the pelvic floor. Okay. But I want to talk through today some of those possible causes, just kind of high level. So I can kind of drive my point home that the pelvic floor is the victim here. So there's, of course, this might be one of the more obvious ones to us PTs and OTs and coaches, is there's biomechanical causes, right? We know that how the pelvic bones move is going to influence the pelvic floor muscle's ability to contract and relax. Okay. That's length tension relationship 101. Okay. We know that whatever bones or joints a muscle attaches to in general, when those bones move, it will influence the tension of those muscles and their ability to contract. That's the exact theory that we learned in PT school and OT school, I'm sure, whenever we did the little wrist thing where they had you flex your wrist and then try and grip something and then extend your wrist and try and grip something, and you can see the difference, and it's because of the length tension relationship of the muscles of, when you move a joint, it will either lengthen the muscles further or it will shorten them and put them on slack, and that will influence their ability to do things. Okay, so it's the same with the pelvic floor. Pelvic floor muscles attached to the pelvis, and when the pelvis itself moves, it's going to move the pelvic floor muscles, and it will either over lengthen them or it will over shorten them, and that will change the length tension relationship and change the way that the pelvic floor can show up. That's one piece of the biomechanical puzzle. Another one that we have to be aware of is the kinetic chain, okay? And I talked about this a little bit in my foot episode, or a lot in my foot episode, where we really have to understand how the foot interacts with the ground and how the midfoot moves and how the ankle moves. And it kind of is this cascade, this chain reaction up the leg, up at the pelvis. And that biomechanically is going to influence the ilium and what the pelvis does and how it rotates, which by extension changes the length and the tension of the pelvic floor. Okay. And so there's the biomechanical connection from the ground up, literally, ding, ding, ding. That's this whole podcast, that we need to be aware of from a biomechanical perspective. Okay. And then there's also the biomechanical perspective from the top down. So we have rib cage stuff. So when we know that, we have like the infrasternal angle of the rib cage, it can be a little wider, it can be a little narrow. Ultimately, it needs to at least be dynamic, and I'm going to get into that in my rib cage episode. But we have to be aware that as we utilize the rib cage mechanics and as we expand the rib cage and compress the rib cage and rotate the rib cage this way and rotate the rib cage that way, that is going to change the pressure mechanics down at the pelvis as well. And it's going to change where the pelvic bones go. Okay, so that's the biomechanical connection from the top down, is what the rib cage is doing changes what the pelvic bones are doing. And when the pelvic bones move, the pelvic floor muscles that attach to the bones are impacted. Alrighty, so we have to, at the bare minimum, be able to zoom out of the pelvis and look at the full biomechanical picture for our patients from the top down, from the ground up, to be able to start to peel back these layers and ask ourselves why the pelvic floor muscles, biomechanically speaking, are not doing their job. Okay, what is impacting the length tension relationship at the pelvic floor muscles that is prohibiting them from supporting the bladder, from clamping off their urethra, keeping pee in, right? Like all of these things, okay? There's other possible causes. Of course there are, right? We know that the nervous system is a huge, huge, huge driver in muscle tension in general throughout the body, but especially in the pelvic floor muscles. I would argue it might be the most impacted group of muscles, especially in women, by the nervous system. Because, if we look at women, for example, that's a pretty vulnerable area, okay? And that's where we have our womb. That's where we, get pregnant and grow a baby and all of the things. And so it would make sense that subconsciously our brain, our nervous system want to protect that space more than it would want to protect our ankle. I don't know. I mean, I'm a pretty big person that's like, we got to protect the ankle because it's going to impact the pelvic floor. The brain and the nervous system it has one job: to keep us alive and safe. Okay. And if it perceives any threat, whether that's a bear chasing me or whether that is I'm stressed about a work deadline. Okay. Any amount of threat, our nervous system is going to be on higher alert. And whenever that becomes a chronic state, whenever we're on chronic nervous system overdrive and sympathetic overdrive, our body and our muscles are going to feel that. And especially as women, it's going to manifest at the pelvic floor muscles. It just is. And so you just have to be aware of the potential drivers of pelvic floor tension, right? Because if you're over here just being like, oh, let's just do some child's pose breathing and some happy baby breathing and call it good, and you haven't actually figured out that the nervous system is driving this tension, you are never going to help this person. Sure, you might not have given them Kegels. I mean, do you want me to clap for you? I don't know, because I'm not going to, because we need to get to the root cause of this pelvic floor muscle tension, and it might be the nervous system. Okay, and that just is a whole rabbit trail that we could go down. But for the sake of time, let's talk about another potential cause. So gut. Okay. This one's maybe a little more obvious because it's like, oh yeah, pelvic floor, one of the jobs is pooping. That's part of the gut, right? And yes, so we need to be aware of gut stuff in our patients. And we need to be able to know what potential gut problems can look like, because it's not always that my tummy hurts. Okay. It could be skin changes. It could be brain fog. It could be food intolerances that might hurt their gut or might cause other symptoms after they eat them. And while it's not our job to be a nutritionist and a dietitian, unless you're like double licensed or something, which could be cool, that's ultimately not our job. Our job, though, as PTs and OTs, is to be aware of potential drivers of our patient's symptoms. And if it's biomechanical, we love a good biomechanical problem, because we're going to fix that and we're going to fix it good. Okay. If it's gut related, we probably need to refer out. Okay. That's the whole part of being better together, which I always talk about. We need good collaborating providers that can help us treat the root cause of our patient's pelvic floor symptoms. Someone with chronic gut upset, chronic constipation, chronic diarrhea, both, it doesn't matter. That pelvic floor is going to be a little pissed off. Okay. And if you just treat the symptom of tension in the back of the pelvic floor, they will never be better, because you did not determine that the gut upset was the root cause of their tension. And then there's, of course, other things. Like there's, like, again, this is an infinite list of things that might cause the pelvic floor to stop working, right? But like things like EDS, hypermobility, past injuries. You know, I always ask my patients, I'm like, hey, did you like roll your ankle 5 times growing up? Because I'm looking at you walk and I like see this right ankle and I'm a little sus, okay? And they're usually like, yeah, I played soccer and I rolled this ankle 17 times in one day. Being aware that there are so many things that will cause the pelvic floor muscles to not work. And it is not because they are weak muscles. It is not because they are tight muscles. We have to figure out why they're presenting weak, okay? And we have to figure out why they're presenting with tension. And we do that by zooming out of the pelvic floor, looking at biomechanics, okay? We got to look from the top down and we got to look from the ground up. Good news, I teach you all of that in my course. That's my entire method of treating. Plug for the course. But it's our job, right? And we do that by asking better questions. We do that by listening to our patients. We do that by building our network of collaborating partners and doctors and chiropractors and nutritionists and personal trainers and massage therapists, like literally all the things. It is our job. It is literally our job to have those things to be able to help our patients get out of this chronic symptoms and really find lasting change and build resilience. Whenever I say like that's our literal job, it matters to me and it's important to me, because I think we all can do a lot better. Even me, like I can do, like the day that we stop improving and the day that we stop learning and the day that we stop trying to do better for our patients is literally the day that you should just quit your job, frankly. We are helping people with very vulnerable problems, and we're helping people with issues that they probably haven't told many people, and they were brave enough to finally come tell someone that I pee my pants or like I have pain with sex or whatever it is. And it's our job to freaking not give up on them and to not just be like, oh, here's some Kegels or here's like some breathing exercises and go about your merry way. Like that's just crap. It's crap. Hopefully me explaining kind of why that's crap throughout this podcast, these 30 minutes, hopefully you're seeing it now too. And my hope is that you would be hungry to be like, yes, like how can I do better for my patients? And how can I learn this stuff and all of these things? How can I ask better questions? How can I be a better listener? All of that is kind of my whole philosophy. It's how I've trained my team. It's what I've put in my No Kegels course. It's the lens in which I treat my patients. It's my entire framework that my company is built on is asking better questions, being a better listener, figuring out the freaking root cause and not settling for things that are just going to manage their symptoms. It's rebuilding and remapping essentially how the brain uses your pelvic floor, right? Because it's not about being voluntary contractions when you sneeze. It's about rewiring your body and your brain to turn on the pelvic floor before you sneeze, okay? And to do that, we have to set it up for success. We have to set the pelvic floor up for success. And in order to do that, we have to find the root cause, okay? And only then, once we found the root cause and once we've began to rewire how the brain uses the pelvic floor and retrain that automaticity, is that a word? I don't know. The automaticness the automatic function of the pelvic floor muscles, then and only then can we truly say that our patients are going to find lasting change and they're going to build that true kind of resilience that's going to serve them well beyond whenever they are your patient and well into, the rest of the years of their life. What is kind of my framework? I want to talk to you guys about this because my fall cohort of my course is coming up and I want you guys to join me. Of course I do, because I want to change the game and I want you to change the game with me. So with this thought, knowing that it's our job as pelvic floor therapists to figure out the why, this is kind of the method I'll teach you in my course. So you are going to learn in the course how to ask better questions. What are those questions? How do I know what to ask? How do I know when to ask them? You're going to learn how to be a better listener. What are questions that you can be asking that facilitate you to actually listen rather than just get, yes, I leak. No, I'm not constipated. No, I don't have painful intimacy, right? Like we want to go beyond these like yes or no questions. Then it's going to teach you to get the freak outside of the pelvis. But Becky, their pelvic floor is failing. I have to assess the pelvic floor. Yes, you are going to assess the pelvic floor and you're going to do a million other things that I'm going to teach you. You're going to zoom out. You're going to learn functional movement testing. You're going to look at biomechanics. You're going to look at how the foot impacts the pelvic floor from the ground up. You're going to look at how the rib cage and breathing impacts it from the top down. And you are going to be building in your initial eval from day one, kind of this functional picture of what the heck is happening at the pelvic floor. Why is it weak? Why is it tight? And what am I going to do about it? I teach you guys in this course to find the low-hanging fruits, okay? That's literally the whole thing, is that on eval day, you are finding what is the low-hanging fruit I'm going to attack today. And then every time you do that person, you're going to find the next low-hanging fruit once you've like chopped off one of them, okay? With every follow-up, every time you see your patient again, you're going to have kind of this working picture biomechanically. You've already asked them a million questions. You're going to ask them a million more as you get to know them. All good things, but you're going to be able to reassess all of these things that you're going to learn on day one to see their progress. You're obviously going to be hearing their progress because they're going to be telling you, oh my gosh, I went on a run. I didn't pee my pants. And I only saw you one time and all you did was look at my foot. And you're going to be like, yeah, I did. Every follow-up, you're going to be kind of redoing these same things. And the whole point being that if we can clean up the system that is the human body, okay, if we can clean up the system, that is when the pelvic floor will be able to work automatically again. That's it. That's all of it. Our goal is to figure out why the pelvic floor is failing, clean up the system by looking at literally everything. And that when we clean up the system, that is what allows the pelvic floor to do its job automatically. And they're never going to have to think about squeezing their pelvic floor ever again. And they're going to like literally love you. They're going to tell all of their friends and be like, oh my gosh, she literally just worked on my rib cage and now I don't have prolapse. And then she's going to send all your friends to you and it's going to be great and your business is going to blow up. I am not saying Kegels are the devil. I'm not out here on this hill of like, Kegels are the devil. They're making everyone worse. I mean, they might be, but that's not the heart of my anti-Kegel argument. What I am simply saying is that Kegels don't make sense, okay? They don't get to the root cause, which means they are not going to rebuild the system that is faulty in the first place, and they're not going to get our patients the lasting results that they deserve. That's really what it comes down to, you guys, is how can we be better for our patients? How can we show up better? How can we help them find lasting change and build resilience? And in the process, how can we change the game of pelvic floor therapy? And it starts by getting the heck out of the pelvis and not giving Kegels and not relying on child's pose breathing exercises to treat your patients for the rest of the time. So if you guys found this helpful today, I would love, love, love if you would do me a favor. I would love if you would screenshot this and share it to your stories, maybe talk about your favorite part, tag me in it so I see it. That would make my day. And also make sure you go to the show notes and join the wait list for my No Kegels course. The next cohort is coming up. I only do them twice a year. And so be sure you're on the wait list because that will make sure that you don't miss it and you don't miss out on the lunch. Okay. So love you guys. Thanks for listening and I will catch you next time.